Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 241 of our pharmacotherapy series, which majors in endocarditis. The first question reads, BFT, a 65-year-old man, presents with chief complaints of anorexia, fever, chills, and weight loss. His medical history is significant for replacement of his mitral and aortic heart valves, both porcine 1 month ago for aortic stenosis, mitral regurgitation, and mitral stenosis secondary to rheumatic heart disease. 2 weeks later he was readmitted with fever, a right pleural effusion, a pericardial friction rub, and pericarditis. The impression at that time was either post-pericardiotomy or Dressler syndrome. BFT was sent home on anti-inflammatory agents but failed to improve. After continued complaints of anorexia, nausea, chills, and fever to 101 degrees Fahrenheit, he returned to the hospital. On readmission, his physical examination was noteworthy for a systolic ejection murmur at the left sternal border and 3+ pedal edema. Blood cultures were obtained, and routine laboratory studies were performed. His history and clinical presentation were strongly suggestive of PVE. What are the most likely organisms responsible for PVE in BFT? PVE is a life-threatening infectious complication of artificial heart valve implantation that accounts for 7% to 25% of cases of infective endocarditis in developed countries. The prevalence of complications resulting in death has been as high as 20% to 40%. The risk of PVE after surgery is approximately 1% at 12 months and 2% to 3% at 60 months. PVE is categorized as early or late, depending on the onset of clinical manifestations after cardiac surgery. Early PVE occurs within 2 months after surgery and is thought to represent infection acquired during valve placement. It usually is caused by skin organisms that were implanted into the valve annulus suture site where the valve is attached to cardiac muscle at the time of surgery. The most common organisms cultured from patients such as BFT with early PVE are coagulase-negative staphylococci, primarily Staphylococcus epidermidis, accounting for over 30%, most of which are resistant to methicillin, followed by Staphylococcus aureus, accounting for 20%, and gram-negative bacilli accounting for 10% to 15%. Miscellaneous organisms, such as diphtheroids and fungi, account for the remainder. In contrast, streptococci are a more common cause of late PVE that is beyond 2 months after surgery. Nosocomial bacteremia and fungemia in a patient with prosthetic heart valves contribute to a significant risk for the development of PVE. One study noted that bacteremia caused by staphylococci and gram-negative bacilli resulted in 55% and 33% of subsequent PVE cases, respectively. Another study observed the development of PVE in 25% 11 of 44 of patients after nosocomial candidemia. The next question reads, what measures can be taken to prevent early PVE? The overall frequency of early PVE, despite antibiotic prophylaxis, is 1% to 4%. Complications are severe and include valve dehiscence, acute heart failure, arrhythmias, and outflow obstruction. Although antibiotic prophylaxis before valve surgery, a clean procedure, has not been proved to reduce the frequency of early PVE, it is indicated nevertheless because the complications of infection are catastrophic. The antimicrobial regimen used most commonly for cardiac surgery prophylaxis consists of an anti-staphylococcal cephalosporin, such as cefazolin, given in the operating room at the time of induction of anesthesia or within 60 minutes before the procedure. Vancomycin could be considered the prophylactic agent of choice for cardiovascular procedures, including prosthetic valve replacement and implantation of prosthetic grafts, in the presence of any of the following. A. Documented penicillin allergy. B. Prior receipt of broad-spectrum antimicrobial therapy and high likelihood of being colonized with cephalosporin-resistant staphylococci or enterococci, or C. Performance of the procedure in a center experiencing outbreaks or a high endemic rate of surgical infection with methicillin-resistant staphylococci. The next question reads, what are the treatment options for BFT? As noted earlier, BFT most likely is infected with coagulase-negative staphylococci. For those rare coagulase-negative staphylococci that remain sensitive to beta-lactams, which is less than 20%, a penicillinase-resistant penicillin, such as nafcillin or oxacillin, is the drug of choice for the treatment of PVE caused by methicillin-resistant, coagulase-negative staphylococci. Vancomycin should be used. Most staphylococci are sensitive to vancomycin at concentrations of 2 micrograms per milliliter or less. However, strains of staphylococci with intermediate susceptibility to vancomycin have emerged. The AHA currently recommends the use of triple drug combination, vancomycin, gentamicin, and rifampin, therapy for the treatment of PVE caused by methicillin-resistant, coagulase-negative staphylococci (MRSE). When isolates of MRSE are resistant to all available aminoglycosides, aminoglycoside treatment should be omitted. A fluoroquinolone active against the isolate may be considered as substitute for the aminoglycoside in the 3-drug regimen. In addition to medical therapy, most patients also required valve replacement surgery. Although alternative agents such as quinapristine, dalfopristine, linezolid, daptomycin, telavancin, ceftaroline, dalbavancin, and eretavancin have shown potent in vitro activity against coagulase-negative staphylococci, clinical experience in the treatment of infective endocarditis caused by these strains is lacking. The next question reads, STJ, a 36-year-old human immunodeficiency virus (HIV) seropositive man with a long history of IV drug abuse, was admitted to the hospital 4 months after being released from the state prison. His chief complaints included fever, night sweats, pleuritic chest pain, shortness of breath, dyspnea on exertion, and fatigue. Physical examination was remarkable for a temperature of 101.2 degrees Fahrenheit, splenomegaly, and a pansystolic ejection murmur at the left sternal border, best heard during inspiration. The chest radiograph revealed diffuse nodular infiltrates. TTE was positive for a small vegetation on the tricuspid valve leaflet. Significant laboratory results included the following. WBC count of 14,000 per microliter with 65% polys and 5% bands. The corresponding SI units are 14 times 10 per liter with 0.65 polys and 0.05 bands. The normal range is 3.2 to 9.8 with 0.54 to 0.62 polys and 0.03 to 0.05 bands. CD4 cell count is 350 per microliter. Hemoglobin is 13.1 grams per deciliter. The corresponding SI units are 131 grams per liter. The normal range is 140 to 180 grams per liter. Hematocrit is 39%. The corresponding SI units are 0.39. The normal range is 0.39 to 0.49. ESR is 55 mm per hour. The normal value is equal to or less than 30 mm per minute. Infective endocarditis was suspected, blood cultures were obtained, and all 6 samples were positive for coagulase-positive, gram-positive cocci, later identified as methicillin-sensitive Staphylococcus aureus (Mrsa). How do the clinical presentation and prognosis of endocarditis in the IV drug user differ from that of the non-user? What impact does HIV infection have on the risk and outcomes of endocarditis in the IV drug user? The annual incidence of endocarditis among IV drug users is estimated at 1% to 5%. Parenteral cocaine addicts have the highest risk. The presentation, pathophysiology, and prognosis of endocarditis in those who acquire the disease secondary to IV drug use differ from those in non-users. Staphylococcus aureus is tenfold more likely than other pathogens to cause infection in this population. Staphylococcus aureus is part of the normal skin flora and is introduced when the illicit drug is injected. The following are differences between addicts and non-addicts with Staphylococcus aureus endocarditis. Addicts are significantly younger, they have fewer underlying diseases and more right-sided, that is tricuspid, involvement. In contrast to the predominance of left-sided disease in non-addicts, they are less likely to have heart failure or central nervous system complications, and they exhibit fewer signs of peripheral involvement and have a lower incidence of death. Among patients without history of IV drug use, Mrsa was involved in 1/3 of a cohort of 424 patients with definite Staphylococcus aureus infective endocarditis. Clinical features that characterized Mrsa infective endocarditis were persistent bacteremia, chronic immunosuppressive therapy, healthcare-associated infection, a presumed intravascular device source, and diabetes mellitus. The prevalence of HIV seropositivity is 40% to 90% among IV drug users with infective endocarditis. HIV-related immunosuppression may be an independent risk factor for the development of endocarditis. The next question reads, what are the therapeutic options for treating Staphylococcus aureus endocarditis in STJ? The susceptibility of Staphylococcus aureus to methicillin is the major determinant of which antibiotic is selected to treat STJ's endocarditis. TJ is infected with MSSA. Therapy of choice for methicillin-sensitive strains is a penicillinase-resistant penicillin, such as nafcillin or oxacillin. Penicillin G rarely is appropriate because nearly all isolates of Staphylococcus aureus produce penicillinase. A 6-week course of therapy with high dose, 12 grams per day, nafcillin is the therapy of choice. Vancomycin may be less efficacious than nafcillin as an anti-staphylococcal agent. IV drug addicts, for the reasons previously identified, have a higher response rate to appropriate therapy compared with non-addicts. In one study, 31 addicts were successfully treated with 16 days of parenteral therapy followed by 26 days of oral dicloxacillin. Addicts with uncomplicated right-sided endocarditis caused by Mrsa have been treated successfully with a 2-week course of combination therapy with a penicillinase-resistant penicillin and an aminoglycoside. In one study, 47 of 50 patients, 94%, were cured after treatment with the combination of IV nafcillin dosed at 1.5 grams every 4 hours, and tobramycin dosed at 1 mg per kilogram every 8 hours, for a total of 2 weeks. Notably, 2 of 3 patients treated with vancomycin relapsed, resulting in early termination of this arm of study. Thus, vancomycin should not be used to substitute for nafcillin in this regimen. An abbreviated course of treatment can be used in a defined group of IV drug users with right-sided endocarditis. These patients should have the following characteristics. A. Clinical and bacteriologic response within 96 hours of initiation of therapy. B. No evidence of hemodynamic compromise, metastatic infection, or neurologic or systemic embolic complications at either the initiation or completion of 2 weeks of therapy. C. No echocardiographically demonstrable vegetations larger than 2 cm. D. Not infected with Mrsa, and E. Not receiving antibiotics other than penicillinase-resistant penicillins, such as first-generation cephalosporins and glycopeptides. HIV seropositive patients, CD4 counts more than 300 times 10 cells, with tricuspid involvement included in the above studies, also responded favorably to these short-course regimens. Thus, a short-course regimen is an option for STJ. Recent studies suggest that the addition of an aminoglycoside to the treatment regimen does not improve overall response for patients who meet the above criteria for short-course therapy and is associated with increased toxicity. Therefore, the AHA guidelines do not favor the antibiotic combination anymore. Also, all patients receiving the short regimen should be carefully evaluated for evidence of continuing infection or complications before discontinuing therapy at the end of the 2-week treatment course. Extension of therapy with a beta-lactam agent to at least a 4 to 6 week duration is recommended with any evidence of active disease or complications. Although response to antibiotic therapy has been shown to be similar between asymptomatic HIV seropositive and HIV seronegative IV drug users, short-course therapy should be avoided in more immunosuppressed individuals, CD4 cell counts. Let's look at oral regimen. An oral treatment regimen consisting of ciprofloxacin dosed at 750 mg every 12 hours, plus rifampin dosed at 300 mg every 12 hours, has also been evaluated in addicts with uncomplicated right-sided endocarditis. In one small, non-comparative study, 10 addicts were successfully treated with the combination of ciprofloxacin and rifampin for 4 weeks. Ciprofloxacin was given IV, at a dose of 400 mg every 12 hours, for the first 7 days, followed by oral administration, at a dose of 750 mg every 12 hours, for the remaining 21 days of therapy. Another study prospectively compared the oral regimen with standard parenteral therapy for this subgroup. Patients were randomly assigned to receive 28 days of therapy with oral ciprofloxacin plus rifampin or oxacillin dosed at 2 grams IV every 4 hours, plus gentamicin 2 mg per kilogram IV every 8 hours. Vancomycin 1 gram IV every 12 hours was substituted for oxacillin in the penicillin allergic patients. 1 of 19 patients in the oral group versus 3 of 25 in the IV group failed treatment. However, approximately half of the study patients in either group had possible endocarditis. Given the small number of patients who completed treatment, therapeutic equivalency between the oral and parenteral regimens will need to be confirmed in larger trials. In addition, emerging quinolone resistance in Staphylococcus aureus and the compliance and monitoring required of this regimen when administered in the outpatient setting are of concern. Nonetheless, it appears that a 4-week oral regimen with ciprofloxacin and rifampin may be a useful alternative treatment option in addicts with uncomplicated right-sided endocarditis. Next we will consider penicillin-allergic patients. Treatment of penicillin-allergic patients with Staphylococcus aureus endocarditis is somewhat controversial. First-generation cephalosporins have been used with some success for the treatment of patients with mild penicillin allergy, but treatment failures with cefazolin are difficult to explain. The stability of cefazolin when exposed to antistaphylococcal beta-lactamase has been proposed as a mechanism for these failures. Notably, staphylococci are capable of producing 4 penicillinase subtypes, to which the stability of cefazolin varies. These susceptibility differences are apparent on MIC testing only if a larger than usual inoculum is used, i.e., greater than 106 organisms. It is possible that treatment failures with cefazolin may be caused by a combination of the recalcitrant nature of the infection and the instability of cefazolin against a particular subtype of penicillinase produced by the staphylococcal strain, which is not readily detectable via routine MIC testing. For patients with endocarditis caused by Staphylococcus aureus who have immediate-type hypersensitivity to penicillin, vancomycin or daptomycin may be used. Other treatment options include linezolid and quinapristine, dalfo-pristine. Selection of agent depends on organism susceptibility, potential of drug-drug interactions, and host predisposition for development of adverse effects. Next we will consider combination therapy. An enhanced response to combination therapy in the experimental animal model of MSSA endocarditis has prompted clinical trials to evaluate whether the addition of gentamicin to nafcillin confers any additional benefit. The combination of nafcillin and gentamicin resulted in more rapid clearing of organisms from the blood, but the response rates were similar to patients treated with nafcillin alone. As expected, the group receiving gentamicin had a higher incidence of nephrotoxicity. Thus, for the routine management of endocarditis caused by MSSA, the addition of a second drug does not appear to offer additional benefit when a penicillinase-resistant penicillin is used and is discouraged due to the lack of clearly established efficacy and aminoglycoside toxicity. For patients who remain bacteremic or who fail to improve clinically, usually non-addicts, imaging studies are often performed to identify metastatic sites of infection, i.e., occult abscess, with possible need for surgical intervention. The next question reads, how would STJ's therapy differ if he were infected with MRSA? Staphylococcus aureus infective endocarditis involving methicillin-resistant strains has become increasingly common and accounts for up to 40% of cases. MRSA-infected patients have more chronic comorbid conditions, e.g., diabetes mellitus, hemodialysis dependency, and are more likely to have healthcare-associated infection, 76% versus 37%, and an indwelling intravascular catheter or hemodialysis fistula as the presumed source of infection, 60% versus 31%, when compared with patients infected with MSSA. Persistent bacteremia was more common with MRSA infective endocarditis, occurring in 43% versus 9% of patients infected with MSSA. Of interest, in this study, patients with Staphylococcus aureus infective endocarditis from the United States were significantly more likely to be infected with MRSA, to receive vancomycin therapy, and to develop persistent bacteremia. In 20% of patients with MRSA infective endocarditis, identifiable health care contact was absent. MRSA infection is traditionally associated with healthcare contact in the nosocomial setting, but is now becoming more prevalent in the community, that is, community-acquired MRSA. Young and otherwise healthy individuals without the traditional risk factors are infected in the community. Community-acquired MRSA strains are distinct from healthcare-associated strains in that most possess a distinct virulence gene encoding for the Panton-Valentine leukocidin, abbreviated as PVL. Expression of this pore-forming toxin that causes severe necrosis in polymorphonuclear neutrophil cells in a rabbit model has been implicated to cause invasive infections, including necrotizing pneumonia and skin abscesses. Specifically, community-acquired MRSA PVL-producing strains causing infective endocarditis have been reported. Next we will consider treatment options. Vancomycin has been the accepted standard of treatment for MRSA endocarditis. Response to treatment, however, is slower than with semisynthetic penicillins, e.g., nafcillin, for MSSA endocarditis. The mean duration of bacteremia in patients with MSSA endocarditis has been reported to be 3.4 days for nafcillin alone and 2.9 days for the combination of nafcillin and gentamicin. In contrast, the median duration of bacteremia for MRSA endocarditis was 7 days for vancomycin alone. Failure rates of up to 40% have been documented in patients even with right-sided involvement. Of great concern is the emergence of resistant strains of Staphylococcus aureus after repeated and prolonged exposure to vancomycin therapy. Either vancomycin or daptomycin at 8 mg per kg IV once daily, up to 12 mg per kg per day, may be used to treat patients with MRSA endocarditis. The AHA recommends daptomycin 8 mg per kg per dose. Vancomycin 30 mg per kg per day in 2 divided doses for a total of 6 weeks is recommended for adults with normal renal function. Vancomycin peak levels are not recommended. Given the emergence of MRSA strains with reduced susceptibility to vancomycin, published guidelines from the Infectious Diseases Society of America recommend a target trough of 15 to 20 micrograms per milliliter, in an attempt to overcome increasing MIC of clinical strains and limited tissue penetration. Measurement of trough serum vancomycin concentrations is typically 30 minutes prior to the 4th dose for patients receiving a dosing interval of every 12 hours. A dosage regimen of vancomycin aimed to achieve an area under the curve to MIC ratio of 400 or an unbound trough at 4 to 5 times MIC of the infected strain has been proposed as the optimal pharmacodynamic target. STJ has been treated with vancomycin 1 gram IV every 12 hours for 5 days for his MRSA endocarditis, but does not seem to be clinically improving. His blood cultures are still positive, and his WBC count remains elevated at 12,500 per microliter with 55% polys and 7% bands. He continues to have a low-grade fever since starting vancomycin. His vancomycin trough level on the 2nd day of therapy was 17 micrograms per milliliter. The infected MRSA strain had a vancomycin MIC of 1.5 micrograms per milliliter as determined by epsilometer test, also known as E-test. What factors may be contributing to STJ's poor response to treatment? What other therapeutic options are available for STJ? In a large multinational study of nearly 1,800 patients with definite infective endocarditis, persistent bacteremia, receipt of vancomycin, and healthcare contact were significantly more common in patients with MRSA infective endocarditis from the United States compared with those from other geographic regions. The authors speculated that the higher rates of persistent bacteremia in U.S. patients may be attributable in part to the receipt of vancomycin therapy. Vancomycin MICs against Staphylococcus aureus have been increasing over the years. At one university medical center, vancomycin MICs were determined by broth microdilution for 6,000 nosocomial Mrsa isolates collected during a 5-year period. In the year 2000, 80% of the strains had vancomycin MIC of 0.5 micrograms per milliliter. However, by 2004, 70% of isolates had MICs of 2 micrograms per meter. In response to increasing reports of vancomycin failures caused by strains that are in the susceptible range, the vancomycin breakpoint for susceptibility was reduced from 4 to 2 micrograms per milliliter for Staphylococcus aureus in 2005 per the Clinical and Laboratory Standards Institute. Widespread use of vancomycin has led to the emergence of glycopeptide intermediate Staphylococcus aureus, abbreviated as GISA, or heteroresistant GISA-H, GISA strains. Reduced susceptibility to glycopeptides results from an increase in the production of peptidoglycan precursors leading to a thickened cell wall and decreased penetration of glycopeptides into the bacterial cell membrane. In the absence of vancomycin H, GISA strains may revert to glycopeptide susceptibility, making it difficult to detect these strains in vitro. As such, several investigators have found that H. GISA strains have an MIC range that overlaps with the currently defined susceptible range and that the prevalence among hospitalized patients is increasing. Routine susceptibility testing methods performed in the clinical laboratory are unreliable in detecting MRSA strains with H. GISA phenotype. MIC determined by E-test best predicts treatment outcome with vancomycin. Experts have recommended a target vancomycin trough concentration of 15 to 20 micrograms per milliliter to overcome increasing MIC when treating pneumonia or endocarditis caused by MRSA. A published study of adult infections with MRSA reported that 54% 51 of 95 of clinical isolates had vancomycin MIC of 2 micrograms per milliliter. Notably, invasive infections, such as bacteremia and pneumonia, were linked to higher MIC. Infections caused by those strains were associated with lower end of treatment responses, 62% versus 85%, and increased mortality, 24% versus 10%, compared with strains with MIC of 1 microgram per milliliter or less, irrespective of attaining a goal trough of 15 to 20 micrograms per milliliter, achieving the goal of 4 to 5 times greater than MIC of an infected strain that has an MIC of 2 mcg per milliliter. Borderline susceptibility MIC 2 micrograms per milliliter and severity of underlying disease were independent predictors of poor treatment response. Many strains demonstrated tolerance to vancomycin as defined by the MBC to MIC ratio of 32, and up to 10% exhibited heterogeneous vancomycin intermediate resistance phenotype, abbreviated as HVISA. Vancomycin monotherapy of HVISA was associated with treatment failure, whereas combination therapy responded favorably. Combination regimens included vancomycin plus rifampin, linezolid, or daptomycin. These findings suggest a role for combination therapy or alternative agents when treating invasive infections caused by MRSA strains with borderline susceptibility. However, the above study was not designed to compare the efficacy of vancomycin monotherapy with combination therapy for the treatment of MRSA infections, and the sample size of patients infected with HVISA in this study was small. Therefore, the role of vancomycin as the treatment of choice for MRSA infective endocarditis will need to be re-evaluated against other available treatment options. Despite attaining a pharmacodynamic goal of unbound vancomycin trough level of at least 4 times MIC of the infected strain, STJ fails to clinically improve and has persistent bacteremia. It is possible that STJ is infected with AH-Visa strain, thus, a change in therapy is warranted. Daptomycin, marketed as Cubicin, is a cyclic lipopeptide that has been approved for treatment of Staphylococcus aureus bacteremia and right-sided endocarditis. In vivo, it has a wide spectrum of activity against gram-positive bacteria, including Staphylococcus aureus, including Mrsa, Enterococcus faecalis, Enterococcus fischum, Streptococci, and most other species of aerobic and anaerobic gram-positive bacteria. It was approved for the treatment of Staphylococcus aureus bacteremia and endocarditis in a non-inferiority study in patients receiving daptomycin or standard therapy consisting of an anti-staphylococcal penicillin or vancomycin in addition to low-dose gentamicin. Successful outcome was seen in 46% 41 of 90 of patients who had presumed or definite staphylococcal endocarditis at their baseline diagnosis. Of those, Mrsa endocarditis was successfully treated in 42% 15 of 36 of cases. In patients with confirmed uncomplicated and complicated right-sided endocarditis, treatment success was similar between the daptomycin group 8 of 18 and the group receiving standard therapy 7 of 16 at 44%. Microbiologic failure occurred in 7 patients in the daptomycin group and in 5 patients receiving standard therapy. Overall, the most common cause of daptomycin failure was persistent or relapsing infections, accounting for 16% of failures. In contrast, failure of standard therapy was more often the result of treatment-limiting adverse events, accounting for 15% of failures. Increase in the MIC of the infected strain was observed more often in the daptomycin group compared with standard treatment, 6 in the daptomycin group versus 1 patient in the standard therapy group. The use of daptomycin for treatment of left-sided endocarditis is not established because only 9 patients were treated and only 1 had treatment success. Daptomycin dosed at above 8 mg per kilogram per day for a total duration of 6 weeks should be used for the treatment of endocarditis. Considering its concentration-dependent effects, some recommended higher doses, up to 12 mg per kilogram per day, which appear to be safe. High-dose daptomycin should be considered in patients who have previously failed vancomycin treatment, who are severely ill, or who are infected with an isolate with elevated vancomycin MICs. Daptomycin should be dosed based on total body weight because obese patients have a larger volume of distribution as well as increased clearance compared with the non-obese population. Creatine kinase levels should be obtained at baseline and weekly to monitor for elevations, and more frequently in patients who may be at risk for developing skeletal muscle dysfunction. High-dose daptomycin at 8 to 12 mg per kilogram daily should be considered as alternative therapy in STJ emergence of cross-resistance to daptomycin after vancomycin exposure has been documented. Similar to a thickened cell wall contributing to decreased susceptibility to vancomycin, the same mechanism is thought to contribute to daptomycin resistance in Staphylococcus aureus. Therefore, it is important to confirm Mrsa susceptibility to daptomycin when used in a patient who had prior vancomycin exposure. Either gentamicin at 1 mg per kilogram every 8 hours or 5 mg per kilogram daily, or rifampin 300 to 450 mg orally twice daily, or both may be used in combination with daptomycin as in vitro synergy has been demonstrated for the combinations. Alternatively, daptomycin 10 mg per kilogram, dose IV once daily plus linezolid 600 mg orally twice daily may be used, particularly with concomitant pneumonia. Once daptomycin therapy is initiated, continued monitoring of clinical response and organism susceptibility to daptomycin is warranted because resistance development has been reported during prolonged therapy. Daptomycin MIC increase during therapy for Staphylococcus aureus endocarditis was demonstrated in 6 patients. Baseline MIC increased from 0.25 to 2 micrograms per milliliter in 5 isolates and from 0.5 to 4 micrograms per milliliter in 1 isolate. 5 of those 6 isolates were Mrsa. A potential treatment option for STJ, if his infected Mrsa strain demonstrates reduced susceptibility to daptomycin, is the addition of an antistaphylococcal beta-lactam agent such as nafcillin or oxacillin to daptomycin based on in vitro synergy studies and few case reports. Linezolid, marketed as Zyvox, an oxazolidinone, is not approved by the U.S. Food and Drug Administration (FDA) for the treatment of endocarditis, but has been used in cases of treatment failures, intolerability to standard therapy, or in infections with multidrug-resistant gram-positive cocci. In a review article that included 33 case reports of endocarditis treated with linezolid, 63.6% of patients had successful outcomes at the end of the follow-up period. Mrsa and vancomycin intermediate Staphylococcus aureus were the most common pathogens, accounting for 24% and 30% of cases, respectively. Failure with linezolid treatment was documented in 7 cases, including 4 deaths attributed to endocarditis and 3 owing to persistent positive blood cultures. Thrombocytopenia was the most common adverse effect, occurring in 8 of 9 patients. In a compassionate use program, linezolid achieved 50% clinical and microbiologic cure rates at 6-month follow-up in 32 patients with definite infective endocarditis. Mrsa was the causative agent in 7 of those patients. The most common adverse events reported in this group were gastrointestinal system effects and thrombocytopenia, each occurring in 15% of patients. The degree of thrombocytopenia associated with linezolid correlates with the extent of drug exposure, as measured by area under the concentration curve and duration of treatment. Of note, treatment failure with linezolid for Mrsa endocarditis caused by persistent bacteremia has been described in 2 patients and in 1 patient with relapse of infection. Thus, additional efficacy data are needed before linezolid can be recommended for the treatment of infective endocarditis caused by Mrsa. Tedazolid, marketed as Civextro, a novel oxazolidinone, was shown to have only moderate bactericidal activity in vivo in a rabbit model of Mrsa endocarditis and was less active than either vancomycin or daptomycin. At this time, tedazolid cannot be recommended as a primary agent in treatment of endocarditis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 242.